chapter 33, part 1 of burns. So let's get into it. Just a quick little introduction. So burn injuries really are just more common than you might think. So every year about 450,000 people in the US need medical attention for burns. Now thankfully both burn injuries and deaths have decreased over time, and there's several factors for that. One is prevention. So prevention is key, obviously. So public education has helped people understand risks and safety measures, and then stricter building codes. So that makes our homes and workplaces safer. Now, who's most at risk? So young children, thinking about like under 5, and older adults are the most vulnerable. And then another piece of this is that treatments have really come a long way. So we've really learned how to manage this burn shock or hypovolemic shock more effectively. There's also been advances in fluid therapy, antibiotics, and early wound care, like excising dead tissue and using biologic dressings. All of those things have drastically improved outcomes. And then specialized burn teams are really now a big part of the treatment as well. So public safety campaigns too are kind of our last piece that we see there. They really focus on smoke detectors and then also the proper handling of flammable liquids, propane, and fireworks as well. So some A&P. So skin, talking about the skin. You know, it's not just a barrier, kind of a lifesaver here. So the human skin plays a vital role in keeping the body balanced and functioning. So that skin, it's really built to repair itself, as we've talked about numerous times in other lectures. Most of the time, your skin can heal from minor cuts and scrapes and burns. Now, with severe injuries like large burns, it's going to need some help. So when we're talking about the skin, you know, kind of what does it actually do? So let's break it down. We see protection. So the skin is your body's first line of defense, keeping harmful things like bacteria and toxins and the environment out. Also temperature and fluid regulation. So really it's kind of like your body's thermostat. You know, it manages the heat and water loss to keep everything running smoothly. And then it has some sensory connections. So skin is loaded with sensory nerves that send vital information to your brain. So things like pain and pressure and temperature. And then of course there's that whole healing response. So whenever it's injured, your skin triggers this inflammation process to kickstart the healing process. So still continuing with some A&P. So burn injuries can leave lasting effects on the body and of course on the mind too. So here's kind of some ideas. What you see is, you know, some difficulties here. So on your slide, they have some challenges with some body function. So thermoregulation issues. So scarred skin struggles to maintain body temperature. There can be some sweating problems. So scar tissue can't sweat, which affects how the body cools itself. And then impaired blood flow control as well. So those damaged areas may lose the ability to vasoconstrict or vasodilate properly. And then some changes in the skin also. So there's no melanin in the scars. So that means the skin can't protect itself from the sun, and that leads to higher risk of sunburn. Typically not going to be a lot of hair growth, so those hair follicles are destroyed in the injured areas. And then reduced sensation. So scar tissue often has little or no feeling, making it harder to detect injuries. And then as you can imagine, you know, there's a lot of mental health impact as well. So, you know, survivors of serious burns, because that's what we have been talking about with all of this damage is pretty serious burns, they frequently face depression, dealing with the emotional toll of their injuries, and then that whole recovery process. So the layers of the skin. Epidermis, we've mentioned it before, that's just that outermost layer. So think of this as kind of your body's armor. It's your body's first line of defense against the outside world. So it blocks water and dust and microorganisms, even physical stress. And then it's made up of several sublayers. It works hard to protect your body and then to regenerate itself. Then we have the dermis, so that inner layer. That layer is all about strength and resilience. So it's packed with collagen fibers for structure, has those elastin fibers for flexibility, and then it has this gel-like substance that helps it absorb and retain moisture. So part two of this. So within the dermis, you'll find this network of essential structures working together to keep the body, your body functioning. So what's inside that dermis? We see nerve endings, which allow you to feel those sensations. We see blood vessels, which we know supply oxygen and nutrients. They also help regulate body temperature. We see sweat glands, so those are critical for cooling your body and removing waste. And then hair follicles, so they're responsible for producing hair and providing some protection. And then we see some sebaceous glands, so those produce sebum, an oily substance that keeps your skin and hair moisturized. Then we look at the subcutaneous tissue, so that subcutaneous layer, that's beneath the dermis. That's also called the superficial fascia. This thick layer of connective tissue is for insulating, so it helps to hold that body heat in. It's for protecting, so it acts as that cushion to absorb shocks and protect underlying muscles and bones. And then of course there's energy storage, so it stores fat as a reserve for energy. Now the eyes are very sensitive to burn injuries, so even just minor exposure to heat, light, or chemicals can cause some serious damage. So, what happens during a burn injury to the eye? Well, the thin protective membrane that covers the surface of the eye, it's especially vulnerable. So damage can occur quickly, especially with chemical exposure or intense heat. Now there's some key factors that are within chemical burns specifically. So pH, when we see that higher the pH of a substance, so when we talk about like alkalis, the more severe the damage to the eye. And then rubbing, which is what we want to do, that makes it worse. So, instead of rubbing, we want to move to immediate irrigation. That's going to be crucial to reduce harm and then protect those eyes' delicate tissues. So some pathophys. So soft tissue injuries. So burns happen when destructive energy, and we're talking about radiation, heat, or electricity, when that's transferred to the body. So these are the things that cause this soft tissue injuries. This energy damages the skin and the underlying tissues, and that disrupts their essential functions. So when we start talking about some consequences of that, burn victims, they're at a high risk for several serious complications, infection. So without that protective barrier, bacteria can easily enter the body. And then of course, burned skin struggles to regulate the body temp. So we can think about some hypothermia, which leads to dangerous heat loss. And then hypovolemia. Burn injuries can cause severe fluid loss, which lead to a low blood volume, which then we can start talking about shock. So that's that combined effects of fluid loss, tissue damage can result in life-threatening circulatory shock. So hypovolemic shock. Why does hypovolemic shock happen after a burn? So burns can lead to shock in two ways. First, you have some fluid loss through the damaged skin. So when the skin barrier is compromised, fluids just escape from the body. And then volume shifts within the body is another component of that. So fluids that should stay in the blood vessels, they leak into those surrounding tissues. Now, kind of what's happening with inside the body, we see some fluid movement. So those healthy cells, they absorb more salt and water from the surrounding fluid, and that ends up disrupting the body's balance. With that, we start to see some blood pressure issues, so the blood pressure drops. So to compensate for that, the body responds with, as you remember, tachycardia, so a faster heart rate, and vasoconstriction. We see some chemical mediators in this process, and they add to this entire problem. Now those substances that they're released during the injury, they can cause inflammation and more tissue damage as well. And then burn injuries can interfere with clotting. So those sometimes lead to excessive bleeding. So we start seeing some coagulation issues as well. So, some of this you might think like, why does this really matter for paramedics? Well, when we recognize the signs of some of this hypovolemic shock, and we're thinking like a low blood pressure, a fast pulse, cool, clammy skin, those things we need to think about immediate action, such as fluid resuscitation, because that can help stabilize the patient and then improve their chance of survival. Fluid resuscitation, as we'll we'll talk about is one of the biggest components of positive outcome for this. So remember, shock, it doesn't just affect that one part of the body, it impacts everything. So when a patient is in shock, their entire system is under stress. Now, how does it feel for the patient? Obviously, they might experience some chills and some nausea, which can be some early warning signs. And then the things that are happening inside the body, so oxygen and glucose delivery is limited. So tissues can't get the fuel that they need to function. And then of course those waste products build up. So without proper circulation, the body struggles to remove harmful byproducts from the tissues. So this makes us think about why is fluid resuscitation critical. So we've got to replace those lost fluids to help restore circulation, ensuring that oxygen, nutrients, waste removal, that's back on track. Now we know that just these fluids aren't necessarily going to do that. They're not going to help unload oxygen and all of that, but it just starts that process. It helps to restore the circulation so that can work at the best a patient is able to process these things. So what causes a thermal burn? So burns happen whenever that skin is exposed to typically a temperature above 118, or when the heat absorbed overwhelms the tissue's ability to dissipate it. So there are several factors that affect the severity of a thermal burn, and that's going to be the source, the heat source, as well as the time. So that heat source, those higher temps, they're more concentrated heat or larger amounts of heat energy, they actually cause more damage. And then the longer the skin is exposed, the worse the injury as well. And then we talk about kind of a really dangerous situation is those enclosed spaces. So those patients that are trapped in confined areas, they face additional risks from accumulating toxins like carbon monoxide or cyanide, which can complicate the treatment and the recovery of that patient. So we're still talking about some thermal burns. So kind of just some types of them as you see listed. So understanding these types kind of will help you assess and treat the burns appropriately. So flame burns, which are the most common, these burns happen when clothing or skin directly contacts the flames. And flames burns often penetrate deep into the skin, affecting multiple layers. There's also some inhalation risks. So flame burns can also be associated with inhalation injuries, especially if that patient is, as we just talked about, is in that confined space. Then we have scalding burns. So we're thinking about hot liquids. So spilled food and beverage, those kinds of things can cause these burns. Obviously other things can, but it's just whatever can cause a scald injury. So liquids spread quickly over the body. So scald burns often cover large areas of the skin. So we're talking about, just a large surface area. And then around 370,000 scald burns occur every year due to spills from hot food or drink. So they're pretty common really when we're talking about burns. And then contact burns. So we're thinking about hot objects. So these occur when the skin touches something like maybe a stove or a hot iron or another heated surface. Typically these are less deep. So those contact burns are usually less severe because of the body's reflexes that protects against prolonged exposure. Now, one of the things to think about with this is this can be an abuse indicator. So in vulnerable populations, thinking about children, elderly, or even disabled individuals, contact burns with specific patterns or in unusual areas like genitalia or the buttocks may indicate abuse. Then we move down to steam burns. So topical scald burns, basically, steam can cause the burns similar to those from hot liquids. A common source of steam burns is when people, like you peel away that plastic wrap from microwave food and that steam just puffs up, into your face or wherever. And then there's some inhalation trauma as well with these steam burns. So steam inhalation can cause damage from the vocal cord, above the vocal cord. So we're thinking supraglottic. But it rarely causes deeper injuries in the airways, and that's subglottic. And then flash burns. So they're rare but intense. So those flash burns occur from explosions or even lightning strikes. So these burns are typically brief, but they can cause significant damage. Now, the burn zones, they don't affect the body evenly. So there are different zones of injury, and each with its own level of damage. So these zones help us understand how the burn is progressing, and then it also helps to guide treatment decisions. So the first thing we talk about is the zone of coagulation, and we're talking about the core of the burn. I realized I can now do that, so here's what we're talking about. Not that you can't read this, or over here, I'm sorry, the coagulation. But we have the zone of coagulation, so the core of the burn. This is the area closest to the heat source where the most severe damage occurs. Now, one of the big issues with this is there's no blood flow. So those tissues here experience profound cellular changes, and then they have little or no blood circulation that helps that makes healing much more difficult. And then we have the zone of stasis, as you can see we're talking about here. The zone of stasis, that's the surrounding area. So this area surrounds the zone of coagulation. That's where blood flow is decreased, and then the inflammation sets in, talking about the zone of stasis. Now, there is a risk of necrosis, so if that blood flow isn't restored within 24 to 48 hours, this zone can progress to tissue death. And then we have the zone of hyperemia, which you see over on the right. So this is the least affected zone, where the burns is much milder. Recovery is expected, so cells here typically heal within 7 to 10 days. Now, the reason that we're talking about this is, by understanding these zones, hopefully that will help you prioritize care. Because the zone of coagulation will need more urgent interventions like fluid resuscitation, pain management, while the other zones may heal with less intensive treatments. Burn depth. So the severity of a burn isn't just about how much skin is affected, it's about how deep the damage goes. So burns are classified into several different categories, and they're all based on their depth. And then knowing these categories helps you prioritize care. So we have several different types of burns. I mentioned we got superficial, so think first degree burn. So that affects only really the outer layer of skin, so the epidermis. So that skin may look red and swollen, but it's usually not very painful. And then partial thickness, second degree burn. These burns affect both the epidermis and the dermis. So the deeper layer, that skin will be red, blistered, very painful. And then full thickness or third degree burns, those burns will penetrate through all the layers of the skin, affecting the deeper tissues. And that skin can appear charred or white or leathery. There may be little or no pain in the area, and that's because those nerve endings have been destroyed. And then sometimes you see fourth, fifth, sixth degree, but we're talking just about those deeper burns. So these are subdermal burns. They go beyond the skin, affecting tissue, muscle, and even bone. So don't focus too much on categorizing these burns in the field, because burns can look different within hours, and further assessment in the hospital is needed. So your priority will be stabilizing the patient and then addressing their immediate needs. And what I mean by that is airway, fluids, pain management. So, while it's helpful to really understand the burn depths, talking about in the field, so your focus in the field should be on stabilizing the patient, not necessarily categorizing the burn. So we want to look at the burn's appearance, but focus on treating life-threatening issues. So our ABCs, right, that primary ABCs, and then preparing for transport as well. So we're still talking about some burn depth things. So there's some other key considerations. There's not just one factor when we're talking about this. So important factors beyond burn depth, we have exposure time. So how long that patient was exposed to the heat or source of the burn can affect the severity. So longer exposure generally means deeper damage. And then the age of the patient also can really be a big factor. So the elderly and children, they may suffer more severe burns because their skin is thinner and more fragile. And then skin thickness. So some areas that have thinner skin, like the face or the genitals, they're more prone to severe burns than areas with thicker skin, like the palms or the soles of the feet. And then there's concomitant injuries and pre-existing medical conditions. So if the patient has other injuries, so like fractures, so maybe they were in a car crash, or they just in some kind of other damage, or conditions like diabetes, cardiovascular disease. Those things can really complicate treatment and recovery for these patients. So you also need to estimate the total body surface area. So we want to approximate kind of just the extent of the burn, and you'll see that as like a TBSA, so the total body surface area that's burned to help guide the treatment decisions like fluid resuscitation. So really understanding these factors, it helps you assess the overall severity of the burn, helps you make informed decisions about fluid replacement, airway management, transport priorities. Once again, we want to focus on the big picture, so what will give your patient the best chance of recovery. So superficial burns, we've mentioned that affects the outermost layer of the skin, so the epidermis. So while it can be painful, they're typically not serious. So what does a superficial burn look like? So typically red and swollen skin, the burn will appear red and slightly puffed up. There's some blanching. So when you touch the burned area, the skin will blanch, or it might turn, or basically what we're saying is it'll turn white, but the color will quickly return once you remove that pressure. Now, what about blisters? So superficial burns, they usually don't have blisters, but the damage is confined to the outer skin, which doesn't form blisters like deeper burns do. And how long do these things kind of take to heal? Typically, they heal on their own within about 2 to 3 weeks with no lasting effects. And then just a common example is just like a sunburn, a classic example of a superficial burn. So partial thickness burn. So that affects both the epidermis and part of the dermis. So they're more serious than superficial burns, but still not as severe as full thickness burns. These burns can be divided into 2 categories. So we have superficial partial thickness burns. So that skin will be red and may look shiny. When touched, the skin will blanch and return to its red color. You'll see blisters or moisture on the surface of the burn. Now, this type of burn can be extremely painful, and even though the skin is damaged, those hair follicles still remain intact. And these burns will usually heal on their own in a few weeks, but they may be some scarring or changes in appearance. Then we talk about deep partial thickness burns. So those burns extend deeper into the dermis and can damage hair follicles, sweat glands, sebaceous glands. The common causes is thinking about like some hot liquids or steam or grease. And these burns are going to be more painful, and they're also going to take longer to heal. So scarring is also more likely. And we move into full thickness burns. So these are the most severe. They destroy both layers of the skin, the epidermis and the dermis, and they can cause long-lasting damage. So what does a full thickness burn look like? That skin may appear white and waxy, brown and leathery, or even charred, depending on the source and then that severity of the burn. So the skin can't regenerate on its own because both layers are destroyed. So this type of burn requires specialized treatment. Now, because the capillaries are destroyed, you'll see no capillary refill. The area will be cold and not have a pulse as well. Interestingly, the sensory nerves are destroyed, so in full thickness section, the burn itself may not be painful. However, those surrounding areas of the burn where the burn is partial, that will still hurt significantly. So full thickness burns usually require some skin grafting to heal properly, as the skin cannot regenerate by itself. So, when we're talking about, kind of why does this matter? Those full thickness burns are life-threatening and require aggressive treatment. That includes fluid resuscitation, of course, airway management. We mentioned pain control. So while you may not need to treat the burn itself directly in the field, it's essential to stabilize the patient and then prepare them for transport to a burn center where specialized care can take place. So subdermal burns. Those are the most extreme type of burn injury, involving all layers of the skin as well as the underlying fat, the muscle, and even bone or internal organs. So these burns go far deeper than just the skin, affecting tissues beneath the skin, including fat, muscle, and bone, as I mentioned, or even internal organs. The sensory nerves, they're destroyed. So because the sensory nerves are completely destroyed, the patient may not feel pain in the burn area itself. Once again, however, those surrounding tissues could still be quite painful. And then subdermal burns can lead to debilitating injuries that may leave permanent disfigurement or even result in long-term disability. So these burns can also be life-threatening, requiring immediate specialized medical intervention. Now, subdermal burns, those require urgent care and rapid transport to a burn center or a trauma center, depending on how you're set up, as they're often complicated by shock, infection, and then damage to those internal structures that we talked about. So our role is going to be to stabilize the patient, of course manage pain, and then prepare for urgent transport to whoever is the right place. So that facility with the necessary resources to treat these such a severe injury. Now, inhalation burns and intoxication. So inhalation burns, these are serious because they can cause significant damage to the airway and the lungs, leading to severe airway compromise. So, how does inhalation burns affect the airway? Well, those heat and toxic chemicals can irritate and damage the lungs and the airway, often leading to swelling, which restricts that airflow, and then it makes breathing a little, meaning probably a lot, more difficult. Where does this kind of happen at is we see some damage to those vocal cords, larynx, and then the lower airway is often linked to exposure to steam or hot particulate matter, which can burn the airway directly. So damage to the upper airway typically happens when superheated gases are inhaled, leading to swelling and inflammation in the throat. So really those inhalation burns, they're definitely can be life-threatening, as they can cause severe airway obstruction and then lead to respiratory failure. So quick recognition, early interventions are going to be critical in this. So if you suspect an inhalation injury, prioritize securing that airway, getting them some O2, and then preparing for rapid transport, once again, to a facility that can manage advanced airway care as well as these burn type patients. So still talking about inhalation burns and intoxication. So smoke and superheated gas inhalation, they're major contributions to fire-related deaths. So in fact, most fatalities in fires are not due to the burns themselves, but they're actually caused by inhalation of toxic gases, airway compromise, or even pulmonary injury. So what can smoke exposure do? Well, thermal burns to the airway, that the heat from smoke or gases can burn the airway, causing swelling, irritation, difficulty breathing. Obviously, there's going to be some hypoxia, so as smoke fills the air, oxygen level drops, leading to hypoxia. So that lack of oxygen in the body, that can quickly cause life-threatening conditions. And then, of course, there's tons of tissue damage, and there's toxic effects from that. So smoke contains harmful chemicals like carbon monoxide, which can cause direct damage to the lung tissue and lead to poisoning as well. So when you're dealing with the patient from a fire, it's crucial to assess the airway for thermal injury and then monitor their O2 levels closely. Now, early recognition of inhalation injuries can make the difference between life and death. So oxygen therapy, airway management, rapid transport, all key in preventing respiratory failure and other complications from smoke inhalation. So carbon monoxide intoxication. Now you may have been wondering about what intoxication means, but carbon monoxide intoxication. So this is really just this silent killer, because carbon monoxide is a dangerous, odorless gas that forms during the incomplete combustion of carbon-based materials. So we're thinking like wood, gas, or even fuel. Now, where does this carbon monoxide come from? So we mentioned that inefficient combustion. So the less efficient the burning process, the more toxic gases like CO are produced. So CO can come from furnaces, kerosene heaters, other heating devices that aren't well maintained. Those are some common sources. And then engines, of course. So CO can also be released by internal combustion engines, which is why it's essential to always vent exhaust to the outdoors, especially in confined spaces. And then there's other sources, so like methylene chloride, that's an industrial solvent. It's metabolized into CO by the body, which adds another risk factor in some workplaces. So we start seeing with this CO and what it does to the body, we see oxygen displacement. So carbon monoxide can displace oxygen in the lungs and the bloodstream by binding to hemoglobin more easily than oxygen itself. Now CO binds somewhere around 250 times more easily to hemoglobin than to oxygen, and that means even just small amounts of CO can severely reduce the amount of oxygen that's available to those tissues. So within this exposure, you can get this progressive buildup. So being exposed to even small concentrations of CO over time can cause increasing blood levels of the gas, leading to more severe poisoning. So CO poisoning can be tricky to recognize because its symptoms often mimic other conditions. So we see things like headaches, dizziness, nausea. So if CO exposure is suspected, high flow O2 is critical in displacing the CO from the hemoglobin and then restoring normal oxygen levels. So it's important to quickly remove the patient from the source of exposure and then transport them to a facility that can provide further care. And what we're thinking about, hopefully, is some hyperbaric oxygen therapy that you have at your access. Oh, sorry. It hasn't happened in a bit, but occasionally that light pops off. I haven't done it for moving around, I guess. So we're still talking about inhalation burns, so carbon monoxide intoxication. So carbon monoxide or CO poisoning, it can be sneaky, and it's important to recognize when to suspect it. So when should you consider CO poisoning? So if a group of people in the same place complain of headaches or nausea, could be a sign of CO exposure. Also, if people feel sick at home, but fine at work or school, the source of illness may be related to CO in the home. Now, what can make this diagnosis tricky is like O2 sat levels. So patients with severe CO poisoning may have a normal or even elevated O2 sat level on a pulse oximeter. So this is because the pulse oximeter detects oxygenated hemoglobin but cannot distinguish between oxygen and carbon monoxide. So essentially it's just reading that hemoglobin and how saturated it is, and because carbon monoxide is completely saturated, it's reading it falsely because it's assuming it's oxygen. So never trust that pulse ox in these kind of cases. Always take a clinical approach, diagnosis, rely on high flow O2 as part of your treatment. So a normal pulse ox reading doesn't mean that the patient's getting enough oxygen. So in cases of suspected CO poisoning, you want to go ahead and get them on some high flow O2 immediately and then transport them for a further evaluation. And like I said before, possibly hyperbaric oxygen therapy. Now, patient assessment. Let's get into that. So really, this is the importance of a thorough evaluations with burns and related injuries. It might not always be obvious at first glance, so it's important to keep a high index of suspicion even if the patient initially appears stable. So there may be no obvious signs of sickness right away. Severity may not show immediately. Sometimes the full extent of the injuries isn't apparent until a thorough assessment's done. So burn damage, especially internal injuries or even the progression of swelling, might not show up on the surface initially. Now, we can see some worsening conditions to this. So, kind of as we're talking about after that initial evaluation. So even if that patient seems stable at first, burn-related problems can develop or worsen over time. So you'll remember that pathology of burns, it continues to progress even after the incident, which means initially minor-looking burns could become much more severe. So after transporting the patient, the hospital may discover that the condition is much more serious than initially thought. So it's important to kind of keep that in mind that, things may not be as they seem. Now, when you're responding to a burn or a fire-related emergency, obviously safety is going to be the top priority. So fire scenes can be unpredictable. Risks such as toxic fumes, explosions, collapsing structures. So your safety and obviously the safety of your team, that must come first. So stage in a safe location where you can provide patient care without exposing yourself to unnecessary risks. Make sure that area is clear of hazards and mindful of ongoing dangers like fire, electrical wires, explosive materials, all of those things. Still talking about scene size up. So talking about some immediate actions. So when you encounter a patient who has been recently burned, going to be several crucial steps to take to stop the damage and then prevent further injury. So we want to make sure that we extinguish the flames and cool the burn immediately. That helps to stop the burning process, and it also allows the body to start beginning the healing process. So don't let what if the patient's clothing is on fire? So don't let that patient run. Running will only fan the flames, making the burn worse. So encourage the patient to, you remember from 3rd and 4th grade, to stop, drop, and roll. So if they can't roll quickly, lower them to the ground, cover them with a blanket, and then pat out the flames. Obviously, we want to remove any smoldering clothing from the patient so it can continue to burn the skin, and then take off any items that may trap heat. So jewelry, watches, those things can cause additional burns as they heat up. And then if smoldering fabric has adhered to the skin, cut it away carefully rather than trying to pull it away. Pulling can cause more damage and also break the skin. Still talking about scene size up. So, why is determining the mechanism of injury all that important within here of what we're seeing? So, we need to understand the cause of the burn by asking, how did this injury happen? So knowing if the burn is from flames, chemical, electricity, something else can help guide your care. We also want to look for additional trauma. So burns don't always happen in isolation. So that patient may have sustained other injuries that aren't immediately obvious. So be sure to check for those signs of other trauma, such as fractures, internal injuries, or head injuries as well. Now always wear appropriate PPE, personal protective equipment, gloves, goggles, masks to protect yourself from contamination. Burn patients may also be exposed to harmful chemicals or even infectious agents. So keeping yourself safe is just as important as caring for the patient. Then of course follow standard precautions at all times to prevent exposure to bodily fluids, blood, any hazardous materials that could be present at these scenes. Now, primary survey. So when we first approach a burn patient, your goal is to quickly assess how serious the injuries are and then prioritize your care. So here's kind of maybe an approach to the primary survey. So, our general impression, we want to look for some clues that might indicate how serious the injuries are. So that initial impression can tell us a lot about what we're dealing with. Serious burns may sometimes cause little or no pain because those nerve endings could be damaged. So don't rely solely on pain as an indicator. So interestingly, the chief complaint from a burn patient might be, I'm cold. That's going to be due to shock or heat loss. So recently burned patients might appear dazed or disconnected. It could be a result of shock, inhalation injury, or just simply the trauma of the experience. Now obviously when approaching these patients with burns, for the patient, they're going to be painful, traumatic. So your calm demeanor can help them feel a little more at ease. Now when we start going into our ABCs, so we want to make sure we really start talking about exposure. So ensure you expose the patient to assess burns properly, but we also want to protect them from further harm as well. Now burns can affect multiple systems, so a complete and careful assessment is going to be vital. And then mental status. So mental status can vary based on the burn injury, so be prepared for different responses. So a combative patient should raise suspicion for hypoxia or even respiratory compromise. Now isolated burns don't typically cause unresponsiveness. So if the patient is unresponsive, look for other potential causes. So things like toxic inhalation, so smoke or chemical exposure could be responsible. And then other life-threatening injuries too. So those things could be present. So always consider additional trauma. Airway and breathing. So when we're assessing a burn patient, airway and breathing are going to be top priorities. So burns can affect the airway directly, especially with inhalation injuries. So be on the lookout for signs of airway compromise. So signs of that airway involvement in burn patients, there's several things that we can look for. Hoarseness or difficulty speaking, that suggests an upper airway irritation. And then coughing, which may indicate that the airway is irritated or inflamed from inhaled smoke or chemicals. Stridor, something you could hear, so that high-pitched sound that occurs with upper airway obstruction, and that indicates possible swelling. Singed nasal or facial hair, it's a strong sign that heat has been inhaled. Facial burns, so damage to the upper airway or close proximity to fire, that could mean that. Carbon in the sputum, so indicating the presence of toxic gases or smoke in the airways. And then just a history of being trapped in an enclosed space. So if that if that patient was in a closed environment, like a building or a car or small room during the fire, there's a higher likelihood of inhaling toxic smoke or fumes as well. So burn patients, they're at high risk for airway compromise, especially when laryngeal edema, so just that swelling to the throat, when that develops quickly, this swelling can obstruct the airway, so it's crucial to spot the problem early. So knowing that, laryngeal edema can develop rapidly, causing the airway to close off. So early endotracheal intubation, that may be a choice that you make, kind of a life-saving choice in these cases, as it secures the airway before complete obstruction occurs. We want to make sure that we listen to lung sounds carefully to assess the extent of respiratory involvement. So when I say that, I'm talking about paying a particular attention to stridor, which we mentioned that was that high-pitched sound that tells us that there might be an upper airway obstruction. We want to look for signs and symptoms of edema, such as hoarseness or difficulty swallowing. Those could signal that swelling is already affecting the airway. And then also we want to consider pre-existing lung conditions. So we understand that patients with conditions like asthma, COPD, that may develop a bronchospasm or have more severe reactions to the smoke inhalation, even if the exposure is minimal. So with some of these patients, cool humidified O2 can benefit these patients with suspected airway burns. What that does is it helps reduce the swelling. Also, by doing that, it improves oxygenation. So if the patient is struggling to breathe, this can buy some time until more advanced airway interventions can be done. So, quickly identifying airway problems and acting fast can prevent life-threatening obstructions. So early intubation and then administering some humidified O2, that can make a critical difference in stabilizing a patient like this. Now, circulation, so managing some fluid resuscitation and shock. So when it comes to circulation in these burn patients, first priority is managing fluid resuscitation to prevent hypovolemic shock, which is a dangerous condition that's caused by severe fluid loss. So fluid resuscitation, it's going to be critical within the first 24 to 48 hours. So after the burn, the body experiences these fluid shifts, meaning the fluid moves out of the blood vessels and then into the tissues. That typically happens 6 to 8 hours after the injury. So during this time, the patient is at risk for hypovolemic shock, so low blood volume. So getting those fluids back into the body is going to be essential. However, pre-hospital care doesn't need to focus on large volumes of fluid right away. If the burn injury happened recently, your focus should be on stabilization and getting the patient to the hospital quickly. Large fluid boluses are usually not necessary in the first few minutes unless the injury occurred some time ago and that patient is already showing signs of shock. So we don't want to delay transport by spending too much time on trying to get vascular access. So if the patient is stable enough to move, get them to the hospital quickly rather than making multiple attempts at IV access. Now, if it's difficult to get an IV in the patient due to burned tissue, you might consider using an intraosseous access. This may be a better option and is quicker, especially in an emergency. So really, fluid resuscitation is a big piece of this. So some timely fluid resuscitation and quick transport are going to be essential to prevent shock and organ failure. And as I mentioned, if getting IV access is difficult, don't waste your time. IO access can often work in these situations for these patients. Now, when assessing a burn patient, it's crucial to evaluate the severity of the injury to decide where to transport them for the best care. So assess the severity to determine the appropriate facility. So depending on the severity and the extent of the burns, the patient may need to go to a burn center or a trauma center for specialized care. We do want to estimate the total body surface area, so that TBSA, that the amount that's burned. So that TBSA helps determine the extent of the burns and then how much of the patient's body is affected. So most practitioners focus on counting just the partial and full thickness burns, as these are the most serious and require immediate attention. You should remember back to your EMT class that you want to use the rule of nines to calculate this burned area. So this method divides the body into 11 segments, each accounting for 9% of the total body surface. So add up the areas that are burned to estimate the total percentage of the TBSA affected. Now, different rules apply depending on the age. So infants and children, they have a different body proportions than adults. So adjust the rule of nines for their age group to get an accurate assessment. So the rule of palms, kind of just this handy alternative for smaller burns. So if the burn is small or it covers less than 10% of the body, or if the shape is irregular, you can use the rule of palms, and it's also just known as the rule of ones, as an easy alternative to the rule of nines. So you use the patient's palm to estimate the burn area. The palm of the patient's hand, excluding the fingers, represents about 1% of their total body surface area. This method is particularly helpful when the burn covers a small, irregular area, or when it's hard to calculate with the larger segments of the rule of nines. So you just estimate how many palms of the patient's body are burned. Each palm counts for 1%. So for example, if the patient has burns on their entire hand, you'd count it as 1% of the body area. So this is the Lund-Browder chart that divides the body into even smaller and more specific regions. What I would just recommend is, depending upon your service and what you're doing, there's multiple ways to do this. However, make sure for school and your registry that you understand the rule of nines and that you're fairly accurate with it too. So when you're preparing to transport these burn patients, it's important to give the hospital personnel a clear report that includes an estimate of burn severity. So that helps them prepare for the patient's arrival and then ensure that they get the right care. So that burn severity estimates, that will change over time. Those burn injuries evolve over the first 24 hours after the incident. So your initial assessment might differ from what the hospital staff observe once the burn continues to develop. So for example, what appears to be a partial thickness burn could worsen as the skin becomes more damaged, or blisters might form where none existed initially. So, giving an early estimate, that helps these hospitals prepare the right level of care and determine if the patient should be transferred to a burn specialty center or even a trauma facility. So that estimated severity, that really helps decide on the type of fluid resuscitation and any other urgent treatments that might be needed before arrival. There is some, so you have the ABA, the American Burn Association. They have a referral criteria. So the ABA provides specific criteria for patients who require transfer to a burn specialty center, also known as just a burn unit. So these criteria include severe burns, which are greater than 20 to 25% TBSA, burns to sensitive areas like the face, hands, feet, or genitals, electrical burns or burns complicated by other trauma, and then chemical burns that require specialized care also. So when to transfer to a burn specialty center? Not all burn patients require a transfer to the burn specialty center, but there are certain situations where it's critical for the best care outcomes. So here's kind of when you should consider transport to a burn unit. So partial thickness burns greater than 10% of the TBSA. So that's a significant burn that often requires more specialized care to manage both the severity and the complications. Burns to those sensitive areas like the face, hands, feet, genitalia, the perineum, or major joints. Now, burns to these regions often affect functional abilities, and they require specialized care to minimize that long-term damage. Full thickness burns in any age group, so these burns are deep and require interventions like skin grafting and then long-term care, of course. And electrical burns, which that includes lightning as well, electrical burns often cause internal injuries, not immediately visible on the skin, and they require specialized care to manage the complicated tissue damage. And then chemical burns. They require rapid and specific treatment to prevent ongoing tissue damage, and specialized centers are best equipped to handle those. So in addition to the major burn injuries that we've already discussed, there are other conditions where a burn specialty center is the best choice for treatment. So consider a transport to a burn unit if they have inhalation burns. So burns that affect the airway or lungs due to smoke or hot gases. Those things can be life-threatening and require specialized respiratory care. Also, burn injuries that are combined with pre-existing medical conditions. So as we mentioned before, maybe a patient that has existing health issues like heart disease or diabetes, managing that burn injury becomes much more complex or complicated, and they may require specialized care. And then burns with accompanying trauma. So when a burn injury is severe enough to be the main threat to the patient's life, but there's also other injuries like fractures, it may need the advanced care of a burn unit to prevent further complication. Burns in children, so kids have different physiological needs. So those burns in children, especially large burns, they require specialized care and attention. And then burns that require special long-term rehabilitation. So some burns can cause significant emotional and physical challenges that require long-term treatment, including rehabilitation, and might need the expertise of a burn center to support this recovery. Now we're still talking about, we're going to talk about history taking. So when you approach a patient with these burn injuries, you want to get a brief history. It's important to understand their medical background. That helps guide your treatment decisions. So here's a couple of things to remember. We mentioned those pre-existing conditions. So even if the burn seems small, patients with pre-existing conditions, as we mentioned, diabetes, heart disease, even respiratory issues, they might be at a higher risk for complications. So those patients may need to be triaged as critical. So always consider their medical history carefully. And then medications and allergies. So we want to make sure that we're asking about allergies and meds, as these things can influence how you manage that burn care. For example, a patient on certain meds might have a slower healing process or be more susceptible to infection. Knowing what the patient takes and any allergic reaction that they've had helps you provide the best care possible. Now, once you've managed the initial steps, it's time to conduct a secondary assessment. So this step involves looking for additional injuries and then addressing any burn complications that may need attention. So here's kind of what you need to focus on. So prioritize other injuries. So always make sure that the burn injuries aren't the only concern. Check for other injuries that might be more urgent. For example, if there's a trauma injury or if the burn was caused by something like an electrical shock, those might require immediate attention. And then look at the burn circumstances. So that can give you clues about the mechanism of injury and help you determine if something more serious needs immediate care. Injuries to the eye are a big thing. So burns to the eyes can be really serious. If you see burns to the eyes, cover them gently with moist sterile pads to protect them while you get the patient to the ER. Circumferential burns, those that go all the way around a limb or a torso, those guys need special attention. So there's typically going to be a lot of edema or swelling that can make that burn area act like a tourniquet. So it cuts off the blood flow to the rest of the body. In the neck, so swelling could block the airway, making breathing difficult. Then around the chest, obviously it could limit the patient's ability to breathe deeply. And then in the limbs, so swelling could cut off circulation, putting the extremity in serious jeopardy. So early intervention with these is going to be crucial. Patients should be transported to the correct medical facility as quickly as possible. So one thing you want to do is make sure that you're monitoring distal pulses. So keep a close eye on distal pulses. So when we're saying that, we're saying those pulses below the injury. Document those frequently to assess if blood flow is compromised. So burn victims, obtaining vital signs can sometimes be a little bit challenging, especially if there's significant burn damage on the arms or extremities. So It's essential to get a comprehensive set of vital signs to help guide your treatment and ensure you're not missing any complications. So we should hopefully assess blood pressure, one of the first indicators that will tell you how well the body is compensating for fluid loss and the effects of the injury. I said hopefully they're not just, both arms and both legs. Many services will carry thigh cuffs as well. So you can use, obviously either arm or cuffs or leg cuffs as well. You should check the pulse to evaluate that circulatory status. So tachycardia is a common afterburns, especially in the early stages of shock. And then that respiratory status, it's going to be critical. So count the breaths per minute and then look for signs of respiratory distress. So shallow or maybe labored breathing. Oxygen saturation is another thing we should be monitoring. So we want to evaluate that oxygenation level in the blood, especially important in patients who might have inhalation burns. And then end tidal, so measuring end tidal CO2, that gives you real-time data about ventilation. So a decrease in the end tidal could indicate hypoventilation, while higher levels may signal hypoperfusion or shock. And then in the event you have a carboxyhemoglobin percentage, so if you suspect carbon monoxide poisoning, such as fire-related injuries, check that the SPCO levels. So those high levels indicate carbon monoxide intoxication, even if the O2 saturation appears quite normal. So once you've completed your initial assessment and you're en route to the hospital, reassessment is going to be vital to track the patient's condition. So here's how you might kind of approach that. So that full body exam and reassessment for significant mechanism of injury. Now, if the patient has experienced a severe injury, so like a high energy burn, it's crucial to continue performing a full body exam and reassessment while you're transporting them. So look for any changes in their condition. Things can shift quite quickly with burn injuries. Now, how often do we want to reassess these vital signs? So we want to keep monitoring these patients' vital signs during transport. The frequency will depend on the severity of your patient. So critical patients, typically you always see reassess every 5. Lower priority patients can be every 15. And there we are. You thought we were going to be at the end, but I tricked you. We're at the to be continued. So we will pick up part 2 next time. We'll see you then.